Hello, hello, hello. We're here again to present the Intra Aortic Balloon Pump Guide for Nurses. My name is Cheryl. I have a 20 plus year of experience in the critical care specialty, specifically cardiovascular ICU. So, cardiovascular surgical ICU. Here we go. Today, you will learn basic concepts about the intra-aortic balloon pump. You will learn about the anatomy of the intra-aortic balloon pump. You will learn about patient assessment and safety while caring for a patient with an intra-aortic balloon pump or IABP. A few definitions to start. Preload refers to the amount of stretch on the ventricular myocardium prior to contraction. Starling's law. An increase of the volume in the ventricle at the end of diastole results in an increase in the volume of blood pumped out, which is the cardiac output. Factors that affect preload include aortic insufficiency, circulating blood volume, and mitral valve disease. Oxygen consumption. Myocardial oxygen consumption depends on systolic wall stress, intraventricular pressure, afterload, and diastolic volume and wall thickness. What is the intra-aortic balloon pump? Well, the IABP is a mechanical device that increases myocardial oxygen perfusion while at the same time increases cardiac output. Increases cardiac output, increases coronary blood flow, increases myocardial O2 delivery. This is a temporary support for the left ventricle by mechanically displacing the blood within the aorta. The concept is systolic unloading and diastolic augmentation. Parts of the balloon pump or IABP. You have a flexible catheter with 2 lumens for distal aspiration, flushing, or pressure monitoring, for periodic delivery and removal of helium gas to a closed balloon, a mobile console. You have a system for helium transfer with the pump and a computer for control of the inflation and deflation cycle. Here is a photograph of it. You can see the 2 lumens, the helium lumen, and then the blood lumen. The balloon pump itself, it has a radio opaque tip. It's usually a 30 to 60 milliliter balloon. There are plastic hubs to secure the catheter to the position. And then you have an art line or transducer, arterial pressure transducer. Okay, so you can see where from the hub to the tip, that's the part that stays inside. And it has a sterile plastic sheath which permits post-insertion adjustment of the catheter. So if it migrates or something like that, they can easily adjust it. And of course, you have your console on the right and the helium. Here is a setup for the CardioSave, a hybrid in IABP console. Now, each hospital or center may have different ones, so you just have to refer to your hospital procedure for which one you utilize, but this is a general setup. Positioning of the balloon pump. Positioning, the end of the balloon should be just distal 1 to 2 centimeters to the takeoff from the left subclavian artery. This position should be confirmed by chest x-ray. Place the IABP in standby when obtaining the chest x-ray to enhance visualization of the balloon pump tip. And here is the optimal positioning of the balloon pump on the left. This is the femoral artery approach. And then on the right side, it's the brachial artery approach. You can see how close it is to the tip is close to the subclavian artery. If it goes beyond there, it can occlude flow. So keep that in mind. And if the balloon goes below the renal arteries, it can occlude blood flow to the kidneys. Here's another view. How does the balloon pump work? The flexible catheter is inserted into the descending aorta. A balloon is at the tip of the catheter. When inflated, the balloon blocks 85 to 90% of the aorta. This balloon displaces the blood in the aorta. This is known as counterpulsation. This sudden inflation moves blood superiorly and inferiorly to the balloon. When the balloon is suddenly deflated, the pressure within the aorta drops quickly. Helium. It's low density, easy to push in and out of the balloon. It's a soluble helium, will dissolve very quickly in the blood if the balloon were to leak into the circulation. For the balloon pump inflation, which is diastolic augmentation, inflation of the balloon occurs at the onset of diastole. At that point, maximum aortic blood volume is available for displacement because the left ventricle has just finished contracting and is beginning to relax, and the aortic valve is closed. The pressure wave that is created by the inflation forces blood superiorly onto the coronary arteries. This helps perfuse the heart. Blood is also forced inferiorly, increasing perfusion to distal organs, the brain, kidneys, etc. Inflation affects aortic pressure, coronary blood flow, and myocardial oxygen delivery. Balloon deflation, which is systolic unloading. The balloon remains inflated throughout the diastole. At the onset of systole, the balloon is rapidly deflated. The sudden loss of aortic pressure caused by the deflation reduces afterload. The left ventricle does not have to generate as much pressure to achieve ejection since the balloon has been forced from the aorta. This lower ejection pressure reduces the amount of work the heart has to do, resulting in lower myocardial oxygen demand. Hemodynamic effects of the balloon pump. For the aorta, it decreases systolic pressure and increases diastolic pressure. For the left ventricle, it decreases systolic pressure and decreases volume. For the heart, it decreases afterload, it increases cardiac output, and it decreases oxygen demand. For blood flow, it increases coronary artery blood flow. Indications for the balloon pump. Here are some of the indications: unstable angina, complicated acute myocardial infarction or MI, mechanical complications of acute myocardial infarction or trauma, refractory unstable angina, acute MI, cardiogenic shock, including right ventricular failure, left ventricular failure, an adjunct to cardiac catheterization, induction and weaning of cardiopulmonary bypass. So a lot of times when people are coming back from the OR, for example, you may hear that they couldn't quite come off totally off the bypass and remain hemodynamically stable. So they added the intra-aortic balloon pump. High-risk cabbages also pre and post-op have this in place or can have it in place. Severe coronary artery disease with hemodynamic compromise, left main disease, support for high-risk coronary interventions, refractory ventricular arrhythmias, non-cardiac surgery for high-risk cardiovascular patients, and severe mitral regurgitation. Here are the contraindications for the balloon pump. Thoracic or abdominal aortic aneurysm, an included aorta, aortic stents, significant aortic regurgitation, moderate to severe aortic insufficiency, severe peripheral vascular disease, active hemorrhage, severe thrombocytopenia, and a contraindication to anticoagulations. With the balloon pump, the person has to be on an anticoagulant. Here are some complications. With the balloon pump, you can have limb ischemia, thromboembolism, aortic dissection, vascular injury like a laceration or false lumen or hematoma, sepsis, heparin-induced thrombocytopenia, a balloon rupture, which can cause a gas embolus. The initial setup. Once connected properly, the console will show ECG and pressure waveforms. Make sure the setting is at auto mode. Operation modes. You have automatic operation mode, tracks the cardiac cycle, cardiac rhythm, and adjusts automatically. Semi-automatic, the operator must adjust the inflation and deflation. Manual, the operator must adjust inflation and deflation and can set a fixed rate. You have to follow your policies really carefully when you have to do this. Most of the time, it's set to automatic. Trigger. The trigger that the IABP use is the event that the pump uses to identify the onset of the cardiac cycle, which is systole. The pump must have a consistent trigger in order to provide patient assistance. If the selected trigger is not detected, counterpulsation will be uninterrupted. Here are the types of triggers. You have an ECG trigger, and it's the R wave. That's the preferred trigger. Must have a reliable R wave, recommended with arrhythmias and pace rhythms. Pressure trigger, systolic upstroke of the arterial waveform. This is a backup trigger when the ECG trigger is not appropriate. Use it during cardiac arrest or CPR. And you have the pacing V and AV trigger event. That's ventricular pacer spike, and it's used with V or AV paced rhythms. Used when 100% paced and no reliable R wave is present. And then you have a pacer A trigger event is the R wave, primarily used in open heart patients who have had temporary atrial pacemakers when the pacemaker tails are present. Internal trigger event. This is an asynchronous balloon. It's asynchronous. Balloon inflates and deflates at a set rate of 80 beats per minute, for example. Used mainly during cardiopulmonary bypass. Of note, during cardiac arrest, the balloon pump can provide very effective perfusion in conjunction with external compression. Since there is no EKG signal or arterial pressure wave to trigger the pump, an internal trigger is selected. This trigger detects the flow of blood caused by compressions and inflates the balloon, providing improved circulations. Good and consistent compressions are a must for this to work. Your waveforms. Okay, here you have your diastolic augmentation waveform, which is at the top. Unassisted systolic pressure, which is right before your diastolic augmentation, and the dichrotic notch. Okay. Assisted systolic pressure is right after it's the waveform at the tip of the waveform right after the diastolic augmentation. Um, and then you have your mean blood pressure, unassisted diastolic pressure, and assisted diastolic pressure. Those are the bottom dips of the waveform. So in these pictures, you can see normal and augmented waveforms. Normal waveform is at the top, and then the augmented waveform you can see is at the bottom. The dichrotic notch is way lower in the bottom one compared to the top. This picture shows an early inflation of the balloon pump. If inflation is too early, the balloon inflates before the aortic valve closes and the pumps blood backward into the left ventricle and increases left ventricular diastolic volume and left ventricular end diastolic pressure, increase left ventricular wall stress or afterload, and aortic regurgitation. That's why it's important to look at your waveforms and make sure they're, normal for the balloon pump. This is a late inflation example. There's a little dip after the dichrotic notch before the diastolic augmentation wave form peak. If inflation is too late, there will be a suboptimal coronary perfusion. Early deflation of the balloon pump. If early deflation is too late, the balloon remains inflated too long, causing increased afterload because the heart is trying to pump against the inflated balloon. This is evident by a prolonged dip in the U wave. You can see it there at the bottom, post augmentation. Late deflation of the balloon pump. This is the most critical time in error. If the balloon remains inflated when the left ventricle enters systole, the left ventricle is forced to contract against the inflated balloon. The result can be acute hypotension and cardiac arrest. The pressure waveform reveals an assisted end diastolic pressure that is higher than the unassisted end diastolic pressure and a drastically reduced assisted systolic pressure. The large arrow in this photo denotes the beginning of the balloon pump inflation. So you can see after the assisted systolic pressure is really, really low. Factors affecting diastolic augmentation. Heart rate, mean arterial pressure, stroke volume, systemic vascular resistance, and IABP timing. How to check if the waveform is acceptable. First, change from 1 to 1 to 1 to 2 augmentation. Check the dichotic notch. See if the augmentation starts at that point. This should produce a sharp V at inflation. 3, check if the diastolic augmented wave is greater than the systolic wave. 4, confirm the end diastolic wave following the augmented wave is less than a non-augmented wave. Management and maintenance care. Well, you have to pay attention to radial pulses, the insertion site, pedal pulses, urine output, um, the balloon catheter tubing, and the flush line. So for assessment for the radial pulses, you want to check your left radial pulse, whether it's weak or check for left arm ischemia. The corrective action is to check the position of the balloon pump, make sure it's in the right position, and you will probably get an order for a chest x-ray to determine that. Insertion site, excessive bleeding from the insertion site. Apply pressure, ensure distal flow. And pedal pulses, limb ischemia detected. Consider removing the balloon pump. Consider insertion via opposite limb. So those are decisions that your attending or ICU physician will determine. IABP interlumen flush line, pressure waveform dampened if using a conventional intra aortic balloon pump. Rapid flush with pump on standby. It's the corrective action for that. Urine output is low. Check the position of the balloon pump. Remember, if the balloon is too low and it covers the area where the renal arteries are, it can affect urine output because there's no perfusion to the kidneys. Catheter tubing, blood observed in the catheter tubing. Stop the pump and prepare for balloon removal. That is a emergency. Okay, so all of these things are very important for you to report if you find any abnormal things when the patient has the balloon pump in place. You also have to remember that to instruct your patient, they pretty much have to be laying in a flat position, keeping that limb straight so there's no kinking in the balloon. Management and maintenance care. Anticoagulation, you want to maintain your PTT between 50 to 70. Chest x-ray daily to check for balloon pump migration. Check left brachial radial pulses hourly. If the pulse is not palpable, there may be a migration forward. The balloon pump, including the left subclavian artery. Check lower limb pulses hourly. Check the insertion site for bleeding or hematoma and infection hourly. Check the balloon pump tubing for blood indicates a balloon rupture. Balloon should be placed in standby immediately if noted, and placement of the patient head down. So in Trendelenburg, the catheter will have to be removed immediately. Ankle flexion extension hourly. If pulse not palpable, there may be a vascular obstruction, a thrombus, or embolus. Monitor urine output hourly. May indicate balloon migration, occluding the renal arteries. Hip flexion is restricted. Head of the bed should not be elevated above 30 degrees. Reverse Trendelenburg position is okay. Use a pressure relieving mattress. Keep a 60 milliliter syringe with a three-way stopcock at the bedside in case of a balloon pump failure. This is used to manually inflate the balloon pump. You want to change your EKG electrodes daily, change the occlusive dressing daily, secure the balloon catheter at several points along the limb. Never leave in the standby mode for more than 20 minutes. This may cause a thrombus formation if left in standby for longer. Check a routine hemoglobin. The patients are at risk for bleeding or hemolysis. Check the platelet count. They are at risk for thrombocytopenia. Check the renal function. They're at risk for AKI secondary to the distal migration of the balloon pump catheter. Weaning of the balloon pump. The timing of the weaning. The patient should be stable for about 24 to 48 hours prior to that. You want to be on the decrease in inotropic support. Decrease in the pump ratios. You go from 1 to 1 to 1 to 2 to 1 to 3. A lot of centers do 1 to 1 to 1 to 2, and then they take it off or DC it. Decrease augmentation. Monitor the patient closely. If the patient becomes unstable, weaning should be immediately discontinued if this happens. Balloon pump removal. Discontinue heparin 6 hours before the removal or per your hospital policy. Check your platelet and coagulation factors. Deflate the balloon. Check your census policy and procedures for guidance to remove the balloon pump. Check the distal pulse and insertion site after removal frequently per your census policy and procedure. So once nurses do not remove balloon pumps. It's usually a physician that does that or a special trained technician. So what we have to do as nurses is just to observe after removal for any bleeding or changes in their hemodynamics. Questions? Well, if you're watching this when it's not live, then you can email for questions at info@cherylpalmer.com. My IG has changed. It is down at the bottom. It's the Cheryl Palmer. And of course, you can reach me through the website links as well. I hope this was informational and helpful to you. And I'll see you next time.